Hi, my name's Claire Paling and I'm a physiotherapist and advanced clinical practitioner working in the United Kingdom. This video is designed to be watched alongside our paper, which was published in Musculoskeletal Science and Practice Journal in 2022. It's a service evaluation of the management of patients presenting to an outpatient physiotherapy department with suspected cauda equina syndrome. This video will provide further explanation of the two figures provided within the text, but if you click on the link below, then that will take you to the full article, which will explain the methods, discussion and conclusion. This is figure 1, and we're going to go through the yellow column first, and then we'll look at what happened to the patients on the right-hand side. So within the time frame for data collection, we had 231 patients present to their physiotherapist with symptoms of potential cauda equina syndrome. And of those, 181 were discussed with an advanced clinical practitioner, and 17 were discussed straight with an orthopaedic registrar. Of those discussed with an advanced clinical practitioner, 45 were discussed with an orthopaedic registrar, resulting in this number of 62 discussed with the ortho registrar overall. Of those 62 patients, 44 were deemed to require referral to the emergency department, and another 5 were sent straight from the ACP to the emergency department, usually due to problems trying to catch the orthopaedic registrar via the on-call service. Of the 49 patients seen in the emergency department, 24 had an emergency MRI and 12 had an MRI at a later date. Of those who had an emergency MRI, 3 had cauda equina compression, resulting in 4 overall having emergency surgery for cauda equina syndrome because of this extra patient here. Now, this patient came from a case where the trust's pathway wasn't followed. Instead of liaising with the ACP, the physiotherapist liaised with the patient's GP, who referred the patient for an MRI at a later date. They were then found to have cauda equina compression and went on to have emergency surgery. There were also 2 patients who had MRI confirmed cauda equina syndrome but opted not to have surgery, and there's more discussion about those cases within the full paper. So this leaves us with this column of patients where no further action was required. So some of those were decided by the physiotherapist after further questioning that it was unlikely they had cauda equina syndrome, and no further action was taken. 131 of the patients discussed with an ACP were decided not to require emergency referral. And 18 of the patients discussed with the orthopaedic registrar did not require emergency referral either, and 14 of those who were sent to the emergency department were deemed not to require an MRI. Now, looking at figure 2, some of those patients who didn't go through the emergency department were referred to the ACP service. So 85 patients were seen on a non-emergency basis by an advanced clinical practitioner. In 29 of those cases, it was decided that no MRI was required, whereas 56 had an MRI on a non-emergency basis. Only 1 of those went on to have surgery for cauda equina syndrome, and that was on a non-emergency basis as well, which means that 55 did not require surgery. There's more detail about each of the cases of confirmed cauda equina syndrome, as well as the methods, the conclusions, and the recommendations for practice in the full paper. I'll post the link below, and thank you for watching.